and stop us getting all screen fatigue. So our second speaker today is another expert in the field, Dr. Abdulhussien. He is an NHS GP working across leadership and management in digital health, AI and innovation. And it's very well versed in NHS and ethics, which he's going to be speaking about with you today. Thank you, Hatim.
Thanks, Shabina. Hi, everyone. So as Shabina says, my name's Hatim. So I'm a GP. I work in a practice in London. And I thought, I guess the first thing to do would be to kind of share why we're here and kind of how I got into this space. And the first thing to say is, having practiced as a GP, particularly in the last few years, we've massively seen a change in the way we do things. And I've always felt that perhaps in our training, and particularly even going back to medical school, we haven't necessarily had enough learning around how we interact and use digital technology, particularly when they're so critical to the work that we do. And so for me, there was a big part of that was to be involved in that space, to be able to allow us to disseminate some of this knowledge and learning, and also be able to make people aware of what's happening within the NHS in this area. So for those of you that are then going to go into work in the NHS, you have a good idea of the types of technologies you will be interacting with. And also some of the benefits and risks of those technologies, some of the challenges that the NHS as a whole needs to overcome to be able to utilise technology in a more effective way. And ultimately what we want to do is improve patient care, but also improve our lives when we're working in the NHS, and make it easier for us to do the things that we want to do, so we can spend more time with patients. We have more time to care for people. So what I want to do is give you a brief overview of what's happening in the NHS and some of the technologies. There'll be crossover to some of the areas that Kieran covered, but with a bit more of an NHS perspective. But before that, I think one of the things that is really important is to understand how the NHS works. And it's a very complex environment that is very difficult to get your head around. And when you're working there in a clinical role in particular, you often don't realise the complexity around how it works and the different kind of bodies involved and the way change actually happens. And recently, and Kamal's on the call, who's a GP trainee who's on placement with us. I showed him this video and he said, I wish I'd seen this in medical school. So I thought I'd start by showing you this video, because I think it is really important to just try and understand how the NHS works. So I'm going to bring up the screen, and it's a video done by the King's Fund. It's on YouTube. It's freely available. Actually, what I need to do when I share screen is just share my audio as well. So there we go. And it should play for you now. But do let me know. Someone do let me know if the sound isn't coming on.
Big changes are taking place across the health and care system. What does this mean for the organisations that make up the NHS? How will they collaborate with other parts of the system? And what will these changes mean for you and me? When the NHS was set up, it focused on treating single conditions or illnesses. Since then, our health and care needs have changed. More of us are living longer, and many have multiple conditions that require regular, ongoing care. However, this hasn't been reflected in the NHS's structure, a patchwork of organisations that often work independently from one another. Navigating this can be confusing and can have a negative impact on our experience of care. So, for some years now, health and care staff and leaders have been working to bring organisations closer together to better meet our needs by working in a joined-up way. Primary and secondary care, social care, mental health and community health services have been seeking to partner with each other in different ways. At a very local level, GP surgeries have been coming together to form primary care networks, groups of practices working together across areas called neighbourhoods. By sharing resources and working closely together with other local people and services, they can provide a wider range of services than a single GP surgery. Health and care organisations have also been working together across larger areas called places, often covering the same area as a local authority, where large parts of the NHS budget are spent. Here, local government, charities, residents and NHS partners can work together to understand and meet local health needs. But previous laws have prevented services becoming even more joined up. The 2022 Health and Care Act aims to change this and make it easier for organisations to work together. But what do these changes look like? Organisations are now coming together across even larger areas to form integrated care systems, partnerships of health and care organisations that plan and pay for health and care services. There are around 40 integrated care systems across England, and although they've existed for some time, the Health and Care Act gives them legal status, as well as new powers and responsibilities. Integrated care systems are made up of two parts: integrated care boards and integrated care partnerships. Integrated care boards decide how the NHS budget for their area is spent and develop a plan to improve people's health, deliver higher quality care, and better value for money. Integrated care partnerships bring the NHS together with other key partners, like local authorities, to develop a strategy to enable the integrated care system to improve health and well-being in its area. NHS trusts are also coming together to form provider collaboratives, new partnerships that can bring together providers such as hospitals, mental health services, and community services. So how are these new structures funded? Integrated care systems get most of their money from NHS England, which is the national body for the NHS in England, and sets the operational priorities for the health system. It's responsible for the health services you and I access day to day, which are inspected and regulated by the Independent Care Quality Commission. The Department of Health and Social Care sets out what the NHS is expected to deliver for the money it gets from the government, which comes from our taxes. It also holds budgets for some of the other areas that have an impact on our well-being, like public health. Throughout these new structures, local authorities play a key role. They receive money locally and from national government, which goes towards funding a range of services that support our well-being and prevent ill health. So, what does this all mean in practice? The Health and Care Act has put in place a legal framework that enables services to work more closely together, so it's easier for you and I to receive the care we need when and where we need it. For these changes to succeed, staff and local leaders will have to work with one another differently, alongside key partners in local government, the voluntary sector, and communities themselves. Of course, services face other challenges like workforce shortages, growing waiting lists, and the impact of the COVID-19 pandemic. While the new structures won't fix all these issues, by enabling services to work more closely together and join up services for patients, it's hoped that the health and care system will be better able to meet our changing health and care needs in the future. Find out more about.
So that's a really nice overview of kind of what's happening in some of the structures of the NHS, and what changes are happening and that might enable us to make change from a digital point of view. And now I'm going to hone in on that digital point of view. So give me a second, I'm trying to bring up some slides. Okay, hopefully everyone can see these. So the NHS about 5 years ago published something called the NHS long-term plan and started to make a plan for what the NHS was going to do in the next 10 years. And actually, if you look at this slide now, you'll see some of these changes have actually come into place. So it talked about how we improve access to healthcare. So when we described access to GP surgeries, many of us will have family members ourselves we want access to our GPs, and we know that can be quite difficult at times. So it started to move towards what we call a digital first access. So for the majority of people, they would be able to access their GP by doing, for example, an online consultation. So completing a form online that goes to the surgery and then the surgery looks at it. It also started to talk about how surgeries could do more work in terms of telephone and video consultations. So many of you now, when you go and try and see your GP or doctor, you'll find, or other healthcare professional within your practice, you'll find that they contact you either by phone or sometimes even video consultations. It also started to think about how we can give more information to people, empower people to make some of the decisions that they need to make about their health and actually have the information that they have around their health. And that led to what we've seen in terms of the transformation around the NHS app, which actually is being accelerated by the pandemic and the ability to be able to have an app that shows your vaccinations, but also you can see your blood results and various other parts of patient access. And in the future, you will probably even be able to see a significant amount of your notes that the clinicians work on. So you'll get some of the information that comes back to you there as well. You will also be able to book appointments from the app or change appointments from the app. And I saw a trial of this the other day of a tool that allows patients who are waiting on a waiting list to see a specialist in the hospital to be able to say, well, actually, I can't make that appointment time. Can I have that rearranged? It also allows us to manage prescriptions better, and people can request their prescriptions through the app. And now, the majority of the prescriptions that I do as a GP are digital prescriptions. So if you think about the tremendous environmental effect of that, of being able to send a prescription for someone digitally directly to their pharmacy, so they don't have to have the green slip that we used to use to prescribe to people, is going to have a tremendous impact from a sustainability point of view. But also makes things a lot easier for us because patients don't have to come in and collect the scripts all the time. And also makes things easier for patients as a result as well. And it also led to changes in 111. So people were accessing urgent emergency services and are calling 111. Well, actually, they can now access 111 online and fill out a bit of a triage, and then 111 will contact them depending on what they've completed online. And so patient care records, patient-facing apps, the use of digital access to services, all of this allows us to create an infrastructure to be able to then do some of the things that we were talking about in Kieran's talk, some of the AI and decision support, to be able to create best practice, reduce variation, allow people to be empowered to manage themselves as much as possible for conditions where they can manage themselves. So that's kind of patient-facing stuff, but also the system has to change. And I've given you an example of what the system looks like. What does the system need to do to be able to take technology forward? Well, it needs to firstly have the right infrastructure to collect data and information from people. So you need electronic healthcare records, and in general practice, we've had electronic healthcare records for many years, but hospitals are now starting to all get their electronic healthcare records, and by the end of 2025, all hospitals should have an electronic healthcare record. It also allows us to think about how we build skills, and this is a great example of that. So the Digital Academy, as mentioned earlier, is there to build some of the skills amongst people that are going to be entering the health and care workforce to be able to work with these technologies in the future. And so part of today is giving you an understanding of the types of technologies you're going to be working with to help you get the skills to be able to work with them when you are working with them. There are some technical challenges that need to be overcome: security, interoperability, and accessibility. And I'll go into those in more detail. In security, I'm sure we've got a talk in the afternoon from a chief clinical information officer. That's someone that leads on digital health within an NHS organisation. And they're going to talk a little bit about some of their experiences and what they've seen in their organisation around security. And then finally, actually working with the people that are developing these technologies. So the technologies are developed in an environment that's usually in universities, so in academia. Research has been done, something has been developed, it's been spun out into a company. Companies more widely, and that goes from small companies to larger companies. And I work I'm a medical director for an organisation called Health Innovation Kent, Surrey, Sussex, and they're responsible for supporting innovation. So what we do is when people are developing new ideas or new solutions, they come to us and we help them navigate how they approach the NHS and who they might go and talk to and how they build the best product. Because actually what you want technology that works for the people in the NHS. It works for patients, it works for staff in the NHS. You don't want technology, you don't want people to say, we've got a technology and this is how it is and this is how you should use it. You want to be able to configure it and adapt it and co-design it to be able to meet people's needs. And so there's been tremendous progress in all of these areas. But why does the NHS need to continue to progress in these areas? Well, firstly, we need new tools. We need to be able to do differently. When I'm in clinic on a Friday, I'm on call, I'm juggling lots and lots of tasks. I've got a lot going on and I'm trying to provide the best care to the patients that I'm looking after. New tools will allow me to do that in a more effective way. But also society are now set up in a way where they want access. They have access to the internet and they want to use that and they have access to devices and they want to use that to be able to manage their health. I'm sure many of you use your devices to look up health problems, because I know I do, and I'm sure some of you are even starting to use new tools like ChatGPT to try and understand health problems, and I'm sure patients are doing that as well. And so if we know people are connected, we need to offer them something to be able to have that access, but also to recognize that not everyone is connected. So this graph, which is from 2018, so things of course will have moved on, shows the level of mobile connectivity across the world. And firstly, the global average was 63%. So recognizing there are parts of the world where actually mobile connectivity is still kind of in its infancy. Having said that, there are parts of the world where actually you've got Northern Europe there, which is 109%. So that means there's more device connections now than people. And in Western Europe, it was 98%, so not far from being at that stage. So the majority of people do have access to one or more than one kind of connections through their devices. And therefore, it makes sense to be able to give them access to healthcare via their devices. We constantly work to improve healthcare, right? And one of the things that you will be learning in your undergraduate courses is around quality improvement. And what I want to highlight here is the approach to digital is no different to quality improvement. It's a part of that quality improvement cycle. It's part of one of the solutions that you might use to improve healthcare, but you need to be able to follow the PDSA cycle. You need to be able to understand what you're going to do, audit what is happening before, make the change that you want to make using a digital tool, but then go back and audit. Did it actually make a difference? And the biggest example I'll give you here is, as a result of the pandemic, and we moved to online consultation tools up at the practice that I work at, and we found that actually we had this online consultation tool, but we weren't using it in the best way. We're also finding a bit of a different measure in terms of the people that were using the tool and getting an appointment compared to people that were phoning in or walking into the surgery. There was difference, and that didn't create fairness or equity. So we started to do a quality improvement project to be able to understand how we best use that tool. And we actually started to map out end to end what a patient might do if they walk into the surgery, if they call the surgery, if they fill out the online consultation. What is the process of how that's managed? And then we looked at how we could improve that process. We looked at what patients actually would benefit from a direct face-to-face appointment or a direct telephone appointment if they provide the right information. We looked at how we support patients to be able to fill out the online consultation tools. We looked at what patient groups shouldn't be expected to fill out an online consultation tool. For example, if they have a language barrier, if they have connectivity issues in their home or don't have access to a device, if they're elderly, and therefore they struggle with digital capability, or if it's regarding a young child and we know we need to act more quickly, actually it might be better just to streamline that in a much more effective way. But also understand where actually in what cases using that tool is really helpful. Where we want to see a picture, for example, if it's a skin lesion, where we might want to collect information around what someone's blood pressure or oxygen levels might be if they have that material at home to be able to collect that information. So it does allow for a real change in the way we practice and can allow for more efficiencies, but you need to follow quality improvement principles. We also know that medical knowledge is rising. So in terms of published literature, we are now looking at every 60 days medical knowledge doubling. How do we keep up to date with all of that information? I heard recently from the BMJ that it can take up to 17 years for something that is evidence to enter practice. How do we quicken that time? How do we get good practice in quicker? How do we keep up to date with all of that information, guidance and best practice that is out there? And technology will allow us to do that. And one of those technologies is obviously artificial intelligence, and that's collecting large data sets and being able to give us actionable intelligence, being able to go and do things that allows us to improve patient care. And later on today, I'll talk a little bit about the analytics continuum and how we kind of move from data all the way through to wisdom. We need to automate some of the tasks that are perhaps require less human intelligence that can then free us up to spend more time to work to our best. So I can spend more time with my patient rather than some of the tasks that I do on a day when I'm in clinic that actually are quite administrative and quite burdensome in terms of time. So that I can also go home on time and see my daughter. So that is really important. It's important to be able to automate and change some of those tasks, and so we should use technology in that way. Society, as I said, has changed as well in terms of how they think about healthcare. So when in the past, medical school used to be or healthcare used to be very patriarchal. You know, we're the doctor, we'll tell you what to do, you go out and do that. And self-care really wasn't really on the map and was generally discouraged. People were expected to come to you and get advice. When I was in medical school, we were repeatedly taught that actually we should be supporting people to provide them with, to be able to do self-care. We should be guiding people along healthcare and what should happen. We should be giving them the right types of information and signposting them to the right types of information that are out there. And we shouldn't be disparaging when someone says, I've looked this up on Google, because actually it's important to understand what they've looked up. It's important to understand what their understanding is. It's important to understand what their expectations are. And all of you will be very well versed in ideas, concerns, and expectations. It's important to tease that out. And so just to say that we move towards this information age of medicine, that people will access information in a different way. They can look online, they can go on ChatGPT, they can speak to their friends and family. And so they will already come with preconceptions about their health. And you as future people that are working in healthcare will actually be translators of some of that knowledge. Will be facilitators to help people understand what they do next or what the best approach is, because we know things aren't black and white. When I'm practicing as a GP, it's not always so clear what the best option is. Yes, there's guidance and yes, there's best practice, but it's a discussion with the person around what's best for them. And that approach will become easier as we get enabled by technology. Finally, we want to improve your education. We can use these technologies to improve education and training and allow you to have a more efficient experience in the way you learn. And we know this, like we know people learn in different ways. There was a really nice report that was done by Stanford a few years ago that found that people are looking for learning online. They're looking for accessible learning. They're looking for learning in their own time. They're looking for bite-sized learning. They're looking for customized, personalized learning. And so we should be providing this. We should be envisaging to provide an environment where we can give you learning that's signposted to your needs. So I'm going to talk about some of the technologies now very briefly, but I'm not going to talk about artificial intelligence because we're going to be covering that in the next lectures in more detail. So one of the technologies that we are seeing emerging in the NHS is robotics, and the majority of robotics is done in surgery. So about 30% of cancer surgery now is done by robotics. And the reason why robotics has been so effective in that space is because it allows the more precise cuts to be made during surgery, and therefore it's less invasive. And therefore it also leads to less blood loss, faster recovery time, better patient outcomes. One of the challenges is it still is a technology that can be quite expensive, so not everyone has access to it, but actually more and more so, you're seeing most places will have some sort of robotics hub and therefore have access to it. One of the big things about using robotics is you need to be skilled to be able to do robotic surgery. So for those kind of aspiring surgeons or people that are going to work in the theatre environment, it's important to be able to know that you're going to need to have skills to be able to understand this technology and work with this technology in the same way that surgeons of the past and theatre staff of the past had to adapt to from open surgery to laparoscopic type surgery and other less invasive techniques. And then we will also see the emergence of robotics in other areas. So we might see emergence of assistance robots, and there are some examples where people are having more prosthetic type applications and stroke therapy to be able to support them to rehabilitate better. There may also be a role for kind of robotics to play in kind of manufacturing and kind of speeding up some of those things in the NHS. There's a role for potential humanoid robots, particularly for isolated patients. So in care homes, for example, this has been trialed. Mobile robots for delivery, and actually last year you saw a delivery by drone of chemotherapy drugs to a rural population or a rural patient, and that's really important because it allows us to give treatment to people that often don't have access to treatment or might have access to less treatment. And then you may see things that can actually allow you to pick up issues with what's happening. So these are some of the emerging ideas around robotics in healthcare, and like I said, in surgery it's very well established now. And going back to that, so smaller scars, less pain, faster recovery time, less blood loss. You know, there are clearly lots of benefits to doing robotics in this way, but we must make sure that people are comfortable, trained, and the technology works. Another technology, and it comes after robotics because it has robotics in its name, but it isn't robotics. It's something called robotic process automation. And I know this slide is slightly wordy, but essentially, what it is describing is a technology that allows you to automate. So what it does is it does end-to-end automation. So in a very unintelligent way, particularly where we are now in the NHS, we're in this kind of assisted RPA, unassisted RPA space, where if I plug my smart card into the computer, I set up the robotic process automation to work, and it will go and do a task that I teach it to do. So it will be something like patient registrations, or in some cases, filing of normal blood results. You teach it a set of parameters. You say these blood results are normal. If it has a red flag, you don't file it. If it doesn't have a red flag, and also this blood test is within this range, you do file it away. There are things that you have to consider with that, though. So, for example, when I started my GP training, I was taught when you look at hemoglobin and it's not got a red flag on it, that doesn't mean it's not normal. It's normal, because there have been cases that we've seen where actually people have had drops in hemoglobin but still been within the reference range. So technology like this, if it's being used for things like blood results, would need to configure itself to understand actually if there is a drop in the hemoglobin, it will pick that up and it will action that. But it is making a significant impact in transferring and improving some of the processes that exist both in hospitals and GP surgeries. The other one is telemedicine, and telemedicine was first described many years ago by the World Health Organization. They were talking about it in the 1980s and 1990s as a technology that would allow people to have better access to healthcare, particularly remote and rural populations in developing countries. But then we saw this start to impact the NHS, and we saw the emergence of technologies initially like Babylon. And I remember when I was a GP trainee, Babylon had come about and was starting to offer this 24/7 access to a GP and video consultations. And I remember still talking to some of my colleagues about this in training and them saying, well, absolutely not. I don't want to do a video consultation. I would not feel comfortable treating someone over a video call. Then the COVID-19 pandemic happened and we all started doing video calls, became more comfortable in doing video calls. And then as a result, we started to understand what we could use video calls for. So for example, if you have a musculoskeletal patient, you can do a really good examination, at least passively over video. You can even have a look at people's legs and might be able to identify early signs of a DVT or a cellulitis over a video call. So trying to understand what you can achieve by a video, you can see what someone's home environment is, and therefore you can understand kind of what conditions they're living in. One of the most blessed things about being a GP is you can go and visit people in their homes and understand what their home environment is. But that becomes harder and harder due to some of the pressures that we're in. And so being able to do that in a, and sorry, give me 1 second, my daughter's crying. I'm just going to close the door. That would be fun for people looking back at the recording. But yeah, so what I was saying is, you know, I love to go into people's home. I love to see their home environment, but sometimes it's not practically possible, and being able to do that over a video call can be really helpful. We also, when we talk about telemedicine, it's not simply doing a video call. It's also using the telephone, which has been a technology that's been around for a long time, but also being able to text patients. And I now collect a lot of information by text. It's very useful for following up patients. It's very useful for collecting information maybe in a week's time to say, how are you doing? You know, did this work? Did this improve things? To then recognize if I need to then speak to that patient again or call them into the surgery. So these tools are improving the way we interact with people. And then therefore it's really important that we learn how to use them in effective ways that do improve patient care. Smartphone applications. There was a time when the NHS had an apps library. Unfortunately, they don't have it anymore. And that's not to say that it wasn't valued. It was just because they've decided to do it in a different way. But effectively, the NHS has started to quality assure certain applications and then start to point people towards some of those applications if they have been quality assured. And they now exist on sort of individual guidance around conditions. But also, NICE has started to look at applications and started to recommend them for certain conditions. So for the first time in history, a digital app was recommended as a first-line treatment option for a condition, and that was insomnia. And now there are digital apps that do cognitive behavioral therapy to allow people to tackle insomnia that are recommended and offered out by healthcare professionals as a first-line treatment. And wearable devices are really interesting because they are starting to collect information. So, you know, on your Apple Watch, for example, you can now see your oxygen levels, or you can see your heart rate. And I saw earlier in the chat, someone mentioned the Aura ring. It's a ring that allows you to, you know, measure sleep, also measure observations. Now, we have to be careful with these because not all of these are registered medical devices. So Omron, who do a blood pressure machine, actually do have a medically cleared MHRA registered wearable that can calculate your blood pressure. But majority of these, like the Apple Watch, is for consumers. It's not made as a medical device, and they're very clear about that. Having said that, people come to me all the time saying, my Apple Watch has told me this, what do I do? So clearly it's going to have an effect in terms of our interactions with people, and we need to be aware how to manage that conversation. So in a 20-year-old who has just had their COVID vaccination, this was a patient that I had, who said, oh, my Apple Watch is now saying my heart rate is 110. I might say, well, actually, that's probably because you just had a vaccination. You might have a little bit of fever after your vaccination. Take some paracetamol, relax, and then re-measure and let me know, and I'll call you back and then you can let me know how it is. However, if a 50 or 60-year-old tells me, my Apple Watch is telling me I've got an irregular heart rate or a fast heart rate, I might say, well, please actually come in because I need to check that out and have a look at that. So you need to think about the context of the person and the individual and also recognize that the information given to you isn't regulated and therefore may not be perfect. Yes, they have an accuracy to a certain extent, but we can't rely on it. You have to rely on your skills. Self-care, point of care diagnostics or portable diagnostics, being able to take diagnostics to the individual. I have one of these lovely stethoscopes, and I think Kieran mentioned it, which allows you to measure someone's heart rate, allows you to look for murmurs, allows you to record sounds for education and training. And in America, they've started to build analytics into it, so you can pick up things like atrial fibrillation, it can pick up heart murmurs itself. And it's really, really great to use. It sounds really good. I can have a better listen to someone's chest. And then for children, I find it really helpful. So being able to stick it on a child and say, what's your heart rate is quite helpful because it can take a while to count someone's heart rate. So clearly there are tools like that are going to help us improve care. Butterfly IQ, which is an ultrasound device that allows you to do ultrasound at the point of care by plugging it into your phone. We might see this enter practice more often, and we might be able to do more point of care ultrasound scans, particularly when they start to put in decision support and artificial intelligence into that tool. And then also more and more normal diagnostics, so things like being able to check someone's troponin or D-dimer or other kind of key biomarkers with the patient, but in a practice is much more helpful than having to send someone to accident and emergency, and much more cost effective as well. Being able to properly measure someone's inhaler technique in the same way as well. I talked about digital therapeutics earlier when I mentioned these CBT type apps. These are apps that are evidence-based that allow people to use the technology for managing or treating a medical disorder. So things like cognitive behavior therapy apps, or things like apps for other conditions like asthma and COPD that allow people to measure how well they're using their medication, how well their asthma control is, and then also feeds back to a clinician on the other end. These are some really interesting technologies that are entering our practice. Kieran talked a little bit about genomics, and this has tremendous power, right? Can actually start to understand the human genome, and can also start to then think about how you collect that data and then put intelligence on top of that. And we can start to predict disease better. We can start to understand whether someone's risk of developing a certain cancer is high or low, and what should be done. But there are going to be significant ethical challenges here. How much information do you want to know? How much information do we actually need to share? So on the flip side of that, you've got actual tools out there that allow people to get information around their genetics and give them some advice around their health. So there's things like 23andMe. So we also need to be aware there's things that are out there and consumers that are using that then they come to a clinician and they say, well, what do you think of this? And I've had that before. I've had that multiple times where someone has done a 23andMe, which is like a gene overview, and said, oh, it's told me I've got this risk of diabetes, this risk of high cholesterol. Can you do some blood tests? What do I do with this, etc. And so that landscape is also changing. The other one is extended reality technology. So that's described as virtual reality. So it's kind of virtual immersion into simulation, augmented reality, where you can put your phone on top of something, like for example, QR code or whatever, and amalgamate something onto the screen. Google Maps is a great example if you want to kind of look on the road while you're walking and direct yourself. And a mixed reality that starts to bring it together. And there's been talk around the metaverse, and there's been the work that Apple are doing with their new devices. There's no doubt that these technologies will have a role, particularly around education and training we're seeing at the moment. So these technologies in many trusts, in many universities, I'm sure many of you are using these technologies in your learning. I had a wonderful demo of this at Queen Mary University not too long ago, of people being able to use these tools in their practice and create virtual simulations of virtual environments that allow them to improve and better their skills. And in the future, you might see some of these technologies enter patient care as well. So, for example, you could have someone in a care home projecting something back to a clinician to then say what they should do. And you might even be able to use augmented reality to see a visual representation of someone's observations. So clearly a technology that will have a lot of value in the future. So now I'm going to move on to some of the challenges. So yes, there's all this technology, but how do we get there? There's so many complexities that we need to overcome. And this slide I know looks a bit busy, but effectively just says that there's a challenge around data. Data is very complex. Some data is structured. So for example, what's the medication? What's the diagnosis, etc. Some information is not structured at all. It's just in notes that people write up, discharge letters, even information outside of healthcare in social media, for example, news feeds, etc. the types of things that we interact with in our day-to-day lives that collect information about us when we decide to accept cookies. And so how do you pull all of this information together to actually do something meaningful with it? Because it being so complex. And so you can see there's kind of how do we, there's so much information, trying to structure it is going to be really difficult. And then also connect that information up. So making sure that actually your GP records can connect to your hospital records and vice versa is really important. And so that's a piece of work that's happening in the background. And there are some standards around that, like, for example, FHIR and HL7, if you want to look up, which can tell you about how you overcome some of these challenges around sharing information from one place to the other to improve patient care. And again, this is just another slide that shows the complexity of some of this data and where it sits and structure and security, etc., that are challenges around how we use data. Technology itself is a challenge, particularly because people don't understand it. So if this image shows almost a black box type situation, which is described as the problem for AI, is people feel like it's too pie in the sky, it's a black box, they don't really get it. So how do we improve that? How do we actually make people understand the technology? One, by increasing the skills, but then two, what do you need to know? So in the same way that you need to know at a very base level how an MRI machine might work, or how a CT machine might work, and what it produces and what you do with that information, the likelihood is for these types of technologies, particularly AI, you will need to know the same. You'll need to know a very brief overview of how it works under the hood, what kind of data it collects, whether that data is the right type of data, and what kind of maybe methodologies it uses, maybe at a very high level, and then go over and flip over and say, well, actually, of the output, what does the output look like? And is that the right type of output that I need to be able to see to be able to make a decision? It needs investment, and we talked about in the earlier video, talked about funding, and funding streams are complex, but it needs investment to be able to accelerate the infrastructure and the use of these technologies. And we need to overcome some of the risks. So firstly, health equity is really important, and ensuring that we have access to care. But don't make presumptions, because I've heard from I've seen cases where homeless people have said actually having access to GP surgeries at a distance was better for them. They felt less stigmatized. They didn't have to go into a waiting room. They could actually speak to their GP on the phone and felt much more comfortable speaking to a healthcare professional at a distance. So sometimes it can improve access to care as well. But we need to have the right facilities to allow people to do that. So we need to have civic centres, people be able to go to a library, people being able to go to maybe other area and fill out these types of forms and have support to fill out the forms to be able to access healthcare. And we need to make sure that actually this is a fair and available system to the majority of people, and the people that aren't able to use it, because we know that 25% of the population don't have digital literacy, have other means that are protected and have the same level of fairness. We also know that there are biases with these technologies, particularly in AI. There's automation bias. So actually, if you're more likely to automate something, you're more likely to trust it or believe it or accept it, and therefore that can lead to concerns if it's not done in the right way. Similarly, you've got ethnicity bias. Some of these data sets are biased from an ethnicity and gender point of view. And so if you have data that's poor, you're going to get poor outcomes as well from it. And we're going to perpetuate some of the challenges that we've already seen in terms of society around equity because of the research and the evidence and the data that already exists. So we need to make sure we have a clear lens on that and how we overcome that. People will feel that actually they'll have a loss of autonomy, and particularly speaking to colleagues, sometimes they say, well, I don't want something telling me what to do. But I think it's important to realize that these are tools that are going to augment what we do. It's about how we work together with them, not how they work aside from us. So yes, we'll always have a level of autonomy, and actually our autonomy comes from how we interact with people, what the conversations that we have with patients. There needs to be clear regulation and evidence based around these technologies in the same way that we'd have in place for medications. For example, you would only prescribe a medication that's licensed in the British National Formulary, or suggest a medication that's licensed in the National Formulary, and that's been approved by NICE and the Medicines Health Regulatory Authority. In the same way for technologies will be the same. Those bodies will need to approve these technologies to say that they work and meet a certain level of standard. And then how does it change the way we work with that person? What you don't want to be doing is sitting in front of a person, but actually just sitting on your computer and not interacting with that person. What I hope this will allow us to do is to actually spend more time looking at the person in front of us and talking to them. Because you could have technology in the background like AI documenting your notes, and that's the technology the NHS is looking at the moment. You could have technology in the background showing you some of the most pertinent information about that person's history and what you need to be considering. Again, that allows you to then have less focus, less time looking at a screen and more time looking at the patient. So what is that impact on that patient-doctor relationship? One, there's a risk because some people might not be comfortable with it, but there are also benefits potentially there as well. So just very quickly, again, regulation, are we there yet? We're not, but it's a journey and things are improving in that space. And ethics is important. The same ethical principles that you have learned in your degrees or learning in your degrees all apply here in terms of autonomy, in terms of beneficence, non-maleficence. So being able to do what's right and do no harm to people, and give and also make sure that people have the right, appropriate ability to be able to consent and understand what's happening with their information, with their data. That's really important that we get that right. We know that it can be difficult to do some of these technologies, and so we need to evaluate them and see if they work. And we know some of the barriers are things like connectivity in people's homes, access to actual healthcare records, the training to use the devices not being compatible with some of the other softwares that we use in healthcare. If we don't overcome these problems, these projects will fail. So we need to make sure we look at these challenges and we make sure we mitigate for them when we are designing these programs and using these technologies. We also need to understand what people think about these technologies. This is a report that was done by the Health Foundation, which is a think tank. So they do lots of really interesting research in healthcare. And they looked at what the public felt and the NHS staff felt about AI and automation a few years ago. And they found that actually first they asked how many people are familiar with AI and automation. The majority of people were not. They then went on to ask, do you feel positive or negative about AI and automation? And generally it's about 50-50 for most people. They then even looked at specific healthcare professional groups. They looked at nurses, allied healthcare professionals, pharmacists, nurses and midwives, doctors, dentists, etc., and started to see, well, what do professional groups feel about these technologies? Are they positive or negative? And we saw some interesting differences there. So, for example, you can see that allied healthcare professionals and dentists and doctors are a little bit more positive than perhaps nurses and healthcare assistants. Now, we'd like to understand why and try and help mitigate for that. Because what we do know is the people that are more familiar with AI and understand what it can do and automation actually are more likely to be positive, because you take away some of that fear and that kind of misinformation. And so 70% of people that had familiarity with AI were net positive, whereas only 30% were net positive if they didn't have familiarity. So that's really important that we build the familiarity and the skills. We also need to know how it's going to interact with what we do, and I've briefly described that before, but this is a really nice visual demonstration of that. So, you know, you've got a clinician, we're used to making decisions based on all the training and experience and literature that was being exposed to us. So all of the things that you are learning right now, but also all the patients that you will see over time. We will also base some of that information on our decisions based on some of the tests that we do. So blood results, imaging results, etc., and some of the underlying demographics. So, you know, what background are they from? What's their age? What's their gender, etc. These types of information will start to feed into these predictive AI models and will give us maybe more tailored, personalized information. And so how do we use that to make the right decision and take the right action? And so this is the kind of environment that I think we'll be working in not too long. And to be honest, we are working in it in a way. So we already have tools that give us predictive analysis, things like Q risk, Q fracture, which give us predictions of people's heart disease risk or risk of developing a fracture due to weak bone density. And that brings me to the end. Some acknowledgements, Dr. Harpreet Sood, Dr. Anthony Chang and Tom Hardy for some of the slides and the content for this presentation. And I'm going to stop there, and we've got hopefully a little bit of time for anyone to pose any questions. Oh, you're on mute, Shameen.
Yeah, I just realised. Had to happen once. I was just saying thank you, Hatim, that that was another very insightful talk, and I think really kind of giving us a good understanding of the NHS and also where technology is going to fit in with that, because it can be difficult when you're starting out. As you were saying, that video was so helpful. I think it helped me, so it's great. I'm just having a little look at the chat to see what's coming up. People are asking. There's lots of thank yous again. No specific questions, but I know that there were some pre-submitted on the forms. And one of the things was a lot of people were asking, as a student, sort of as we're coming into the NHS, how do I get involved? How do I start getting into that digital arena?
Well, you've already started, haven't you? So you started by coming today and trying to increase your awareness and understanding. And I think that's really important. And being able to understand some of the people that are in this space, go and speak to them. You know, I'm always happy to have a conversation and try and kind of help you understand this space and navigate it. I would like to say that, you know, we are doing work in this area in the NHS, so work within the NHS in this area. So, you know, think about who is doing it, you know, people that are doing this work, like the people on this call who are either, you know, working directly with the NHS, within the NHS, or working with the NHS on activity, and talk to those people about the types of projects that you can get involved with that's going to improve patient care. And weave it into your quality improvement projects, weave it into your research as part of your degrees. that's in the first instance how I would approach it. And then we'll keep a lookout, because there will be opportunities, more and more opportunities that are entering traditional training pathways. For example, a couple of years ago, we launched a clinical AI fellowship program that allows doctors and dentists in training to be able to do AI deployment for a couple of days a week. And now that's being expanded to nurses as well. There are other fellowship programs that similar allow you to do digital transformation projects for a few days a week of your time while you're working in the NHS. So look for those types of opportunities to be able to give you the time and the headspace to be able to get involved in this area. And just make sure you are knowledgeable in this space, read up on it, speak to people about it, speak to families, speak to friends, speak to patients that you interact with, get their thoughts back, because you will get a real mix, and that will give you an understanding of some of the challenges. And if you have ideas, there are things that, there are programs to help clinical entrepreneurs. So there are programs like the Clinical Entrepreneur Program that will be opening for applications in a few weeks. So someone that has an idea that wants to develop a new solution, that program will help you to be able to access and navigate the NHS and how you can build that idea out in the NHS. But again, it's a complex area, and I'm more than happy to have conversations. And we'll do more of these webinars that hopefully will give you further insights into people that are doing these types of activity and how to interact with them.
I think that's given them a great start of where to begin and a lot to carry on with. One more question has just come through. So what works are going on within the data security field? Considering the NHS has been hacked into previously, how do we give more confidence to patients who are worried about it?
It is such an important question. So one of the things with healthcare is our data is so personal to us. And that's why actually it can be very complex, and you want to make sure that the data is stored safely and securely. So the first thing to say, there has been a lot of work done in this space, and actually, yes, of course, there have been cases where there have been breaches, but on the whole, healthcare data has always been very secure, and there's been a lot of investment in that space. There is a national program that NHS England are launching around building better cybersecurity in the NHS, and working with regions and hospitals and GP surgeries to be able to do that. There are appropriate safeguards that are then put in place for electronic healthcare records before we even buy them and use them. So some of the companies that we use for our electronic healthcare records need to have certain standards that they need to meet in terms of safety and security. And there are clear processes that we have to adhere to, both from what we call regulators in terms of Europe, like GDPR, for example, and then even local regulators that we have to meet. And if we don't meet those guidelines and those best practices, then we will be fined. We'll get into trouble. We'll have issues in the NHS. So I want to assure you that there are the right processes and the pathways in place to be able to protect people's information and data. But we need to do more to be able to tell people that and make people aware of it.
I think we have more time for maybe one or two more questions, do you think? Yeah, okay. So one that's come through is, can user input contribute towards automation bias? And how do we reduce this risk?
Yeah, so automation bias is, so we talk about in a report recently about an appropriate level of confidence. And one of the things that as people that work in healthcare, we're taught how to critically appraise evidence. So we're taught about reading papers and trying to understand, well, actually, is that the right thing to do? And I would say the same would apply for AI. So where you've got automation, it's about being clear and understanding kind of the processes that might be behind it, but also then trying to get the right level of understanding of how much you trust it, but actually how much of your own intuition, your own ability needs to come in as well to get the right level of confidence in it, so that you hit a bit of a sweet spot. So you're using that automation in the right way. And we are doing some experiments and working with the regulators to try and understand what that might be like and how we unpick some of that. And again, if you want to get involved, that's one area where if you're interested, supporting us with some of that research would be really great.
Excellent. One last one, I think. Sorry, I know people are sending them through, but we've got to make sure we get that break in. So I think there's a query about the fact, essentially, the difficulties with the type of technology which is being used within the healthcare setting, so the quality of it, and using outdated machines and things like that. So they're asking, how do you strike the balance between embracing the new technologies and ensuring reliability of what's currently in place?
Yeah, it's a very hard balance to achieve, but you do need to achieve it because it's about investment in the right way, and it's about prioritizing your investment. So I have a role around AI, and people say, well, actually, AI is really, pie in the sky or really far away. Why should we be focusing and doing AI when we've got to, sort out some of our basic infrastructure? And my argument to that would be, actually, we should be doing both at the same time. So we should be doing enough work to make sure the infrastructure is right. We have the right level of devices, computers out there, and we know that that's going to improve efficiency. But at the same time, we should be horizon scanning and understanding how this new technology will change the way we work. And when that technology is ready and available, because it takes time. So imaging, for example, which is where AI is quite, progressed at the moment, it's taken about 5 to 10 years for it to get to that stage, and to have the right level of evidence for it to be used with NHS patients. So we should be doing that work to be able to evaluate and understand and get it to a point where it's ready to be used, and then make sure it fits into the existing infrastructure. And pandemic was a really good example of that. So a technology that we all use in primary care is the applications to be able to text and reach out to patients. That was ready just to bolt on to the existing infrastructure, and it fit in very well. So a lot of the time you will find that the existing infrastructure can support some of this new technology.
Great, thank you again. I'm sorry, I don't think we can get through all the questions,